Questions, please. Again, if you can wait for the microphone, please. Lady in the middle over there. Lady at the end there as well.
Hi, thank you. I wanted to ask a question about patients that you've referred that you, like you're saying, you don't feel comfortable treating. If they get re-referred back to you with treatment plans that you feel you're unable to provide, what do you do in those cases?
That's a great question, a really difficult one to answer. I have great sympathy with that because my week-to-week, day-to-day job is pretty much that. And I don't think I want to get into the difficulties of NHS care because it's beyond the remit of this discussion, but it's a tricky one. We have lots of patients that we see as consultants and physically cannot take on the patient for whatever reason, whether it's case complexity or something else. I think you still have to go back to the case that if you don't feel happy treating that patient, you shouldn't be treating them. I do think that most of the specialist care institutions, and there's always this primary, secondary care debate, I think most people are sensitive to that. I mean, I certainly understand. I have great sympathy for, I'm an NHS dentist, but I work in a slightly different system to you guys. But I do have sympathy to what you're up against out there. And I think most secondary care institutions do that. But I think if a case comes back from hospital, from a consultant, and you don't feel happy undertaking that work, you still shouldn't be doing it. Because at the end of the day, that's still your responsibility because you have that duty of care to the patient. So yes, you can try, refer the patient back. I've certainly said to people before, which bit of it, they'd say that, which bit of it don't you want to do? And I will often give in slightly. I shouldn't be saying this because I'm going to get lots of referrals after this. But I will say, which bit don't you want to do? Well, can you do this bit? And then I'll work as a shared care to try and find a way around it that way. I think it's important to say we are not trying to, in secondary care, push everything back into primary care just because we can't do it. Where I work at the Eastman, I can pretty much fill all our books with congenital disorders, hypodontia, amelogenesis, dentinogenesis, cancer and cleft. Tooth wear, for example, becomes really tricky because for young graduates, managing tooth wear is a classic example. You might be asked to do a dial, something like that. And again, some people don't feel comfortable doing it. And that's really difficult. And that's the system's fault. That's not your fault. It's not the hospital's fault either. But again, to answer your question, I think if you feel uncomfortable undertaking that work, don't do it. Either write back and say, can I do this, but I don't feel comfortable doing that. Or you may need to talk about other colleagues doing it for you if they feel more comfortable undertaking that work.
Okay, thank you.
Thank you. Question, lady on the end there.
Thank you. How soon would you provide cuspal coverage on posterior teeth after endodontic treatment? So straight away or?
Another good question. I would normally say as soon as possible. If you're happy with the endodontic treatment and it's gone well and canals are patent and you're generally happy with the result, symptoms have resolved. Some people would say if you're going to do a 2-visit endodontic treatment, if they've got a sinus to start with, they shouldn't have a sinus when you come to operate it, and if things have generally shown to be healing, great, get a crown on it. I can't see a reason in delaying. There was an idea, well, I'll wait 3 to 6 months for potential healing. I'd get a crown on it, get cuspal coverage, get the tooth protected. I think the caveat to that is if things haven't gone as well as you might have hoped, so you haven't got down a canal or there's been a blockage or some technical difficulty and you're worried that that may affect the long-term prognosis, there is an argument for putting a good, high-quality long-term provisional in place and monitoring that. I have no issue with that. But again, generally speaking, endodontic areas are going to start to heal. You're going to see evidence in about 3 months. So it's not like we'll leave it a year and we'll revisit it then. But if you're happy with things, get a crown on, get it protected and stop the risk of fracture.
Thank you. Devinder.
Nick, thank you for an excellent overview. You showed a couple of examples of molar teeth where one of the roots was compromised. What's your view on hemisection and extracoronal afterwards? For me, and again, I'm sure Ian will have an opinion on this as well, hemisection for me is bordering on hierodontics. Yes, it's been done. Yes, you can do it. I think there are difficulties in terms of how you restore it after that. So for a molar, for me, if that's hemisected, it's a premolar. So we can't think that we're going to put a molar crown on a premolar because that's going to fracture. There are some indications where perhaps you have a perforation or something that allows that to happen. And yes, that can work. But again, let's go back to what we talked about. If you look at cost benefit, if it's a re-root canal treatment, a hemisection, potentially a post-core crown, and half a unit, or do you take it out and do an implant for long-term predictability? When done well, we know that will happen. It's a difficult one to justify, I think. And there will be times when perhaps an implant can't be done for medical reasons, and yes, you might be pushed that way then. But generally speaking, for me, it's moving towards hierodontics. I don't want to say in front of a periodontist that it is, but I think it's moving that way.
Yeah.
Thank you.
So I don't do an awful lot of that, to be honest.
Okay, lady at the back.
Hello, thank you for a very good speech. What's your opinion, please, with regarding tooth surface loss and adhesive bridges? Would you still bond a resin retained bridge? Say, for example, if a tooth had palatal tooth surface loss and the dentine was coming through.
Quick answer to that is no. So for adhesive bridges bonds to enamel. Dentine bonding has been an amazing revelation, but it's not a predictable bond. It degrades over time, the bond hydrolyzes. So when we put adhesive bridge work on, it's to enamel. If we haven't got enamel, I can't do it. So you're either moving towards conventional or some other form of tooth replacement.
Yeah.
But if you have compromised enamel, you're stuffed, because the predictable bond is your enamel bond, absolutely. So
Lovely.
you've got to be very careful in tooth wear cases.
Thank you.
Nick.
The slight problem I have is that it's not whether they spend 2,500 or 6,000. It's whether they want to spend 48 or 209.
Mm-hmm.
So where does the real world fit around those numbers?
Well, that's going to be moving towards endodontic treatment, isn't it? We know on the NHS that's instantly a financial cost of that is going to remove implants out of that remit. I do think it's important to stress that doesn't mean, we talked earlier on, we mustn't presume they can't afford it. Maybe they can't. They've still got to be given that option of an implant. It's a viable option that they need to know about. But I do think with the remit of that, we are moving towards restoring whatever teeth we can with whatever techniques we can. Things like Niacors, that is pretty cost-efficient dentistry. Root filling if you can, and putting a big amalgam core in. It's no indirect cost, no laboratory fee. That's a predictable restoration with a good bond, and we can get cuspal coverage. And I think that's important. People will often misinterpret the endodontic evidence to say it must have a crown on. That's not true. We say cuspal coverage, and that can be done with amalgam, can be done with composite, with direct restorations. If there are compromises that need to be made, maybe that's where you make them. And again, that's where I think we have to look at it, because yeah, I totally agree, in the real world that's not going to be available for everyone. But again, some of that, with those type of restorations, should lend themselves more towards being able to address those type of cases. But again, we want to keep the teeth in the mouth. That's the aim. As restorative dentists, that's what we should be trying to do.
Thank you. A couple more questions. Gentleman in the middle, just hang on for the microphone.
Hi. Just from a medical legal standpoint, so you had a few restorations and endodontic treatments which were red, but you're comfortable carrying out the treatment, you've explained the risk, patients fully aware, but like you said, some people are gamblers. Where would you go with that?
Again, the red, I think the traffic light system, I don't mean that to say you must, you mustn't, and again, that's going to be different for all of us. You ask any of us in here to treatment plan a case, we'll probably come up with a slightly different answer between all of us. But what I really think it wants to do is it just wants to flag up those type of risk factors for you. And I'm really saying that from a point of view, you then conveying that to the patient. So again, you might have a patient that's got that, we talk about the debonded post crown, and you're going to keep sticking it back on. You're going to tell the patient it keeps coming off. And yes, there are other options that they need to do. If the patient makes the decision to go down that road, that's fine. Again, talk about consent and this idea that it's not a waiver of responsibility. I'm really talking in that context of de novo treatment, bigger treatments. But again, for those type of cases where, as Nick's just said, if an implant or other options are not an option, if the alternative is take the tooth out and leave a space, you might well move into the realms of, well, let me have a go at this. And there's nothing wrong with that, as long as the patient is aware that this is a compromised situation. You can't give the same kind of longevity or promise of success because of those compromises, and you must document that and convey that to the patient. But again, in light of other compromises, there's nothing wrong with doing that.
Thank you. Oh, hands going up all over. In the middle again, please. Lady in the centre.
Thank you for an excellent speech. I just want to ask how much dentine should be missing before you consider a cuspal coverage? In, for example, the picture you had of a very heavily restored tooth, would you consider cuspal coverage if that fails?
So let me just get this right. So you're basically saying how restored does the tooth need to be before you need cuspal coverage?
Yeah.
Yeah, that's a good question. There's no evidence that I'm aware of that says that, for example, a molar tooth that's just had an access cavity, does that need to have cuspal coverage? Probably not. I mean, we know that there's a weakness to the tooth by going through the marginal ridge, which you will do with an endodontic access, but that's probably got enough residual dentine and probably enamel to keep that. And all the studies were looking at compromised teeth. I would also say, how often is it that we have a molar that's just got an access cavity? It's pretty rare, actually. So again, you have to wonder why that is such. But generally speaking, the evidence would say, and what we've got there, is that if posterior teeth, so premolars back,
have any type of restoration in, they benefit from cuspal coverage. I think the caveat to that is if it's just an isolated access cavity, which is pretty rare, you could probably leave that as it is because there'll be intact marginal ridges, and that's a helpful thing to have. But anything more than that, for me, it's cuspal coverage of some kind if you can. And again, that will invariably mean crowns, or as we talked about, onlay restorations, overlay restorations, be that indirect or plastic.
And if it hasn't had endodontic treatment, does it require cuspal coverage if it's heavily restored?
That will depend on the patient, and that will depend, again, on risk factors. So that will go back to the type. I would look at things like the occlusion. So do they have a canine-guided occlusion? Are they mutually protected in excursions with good canine guidance? I'd probably say probably not. If they have lost their canine guidance, they're parafunctioning, they've got potential wear facets, they've got history of snapping other cusps, they're moving for me into an amber and a red to say there are lots of signs and symptoms here that there's a bruxism habit going on. So yes, I might think about protecting some of that compromised tooth tissue with a crown.
Okay, thank you.
Thank you. One more question, gentleman in the middle. He had his hand up earlier.
Hi, yeah, thanks for the lecture. Continuing from the endo question earlier, if you do a retreat endo, would you have a minimum period of time that you'd monitor the tooth before you did a final restoration?
No, I'd probably apply just the same rules as I did before. I mean, very often retreatment cases are going to have some acute symptoms. You might have a sinus. My own endodontic practice is nearly always over 2 visits. I do very little single visit, mostly for that reason, so that you can be sure that what you've initiated biologically has had an effect and hopefully started to heal. And for me, that's common sense. Patients often like that because they come in and start with a problem and then it's gone as you've started to do something. But again, if I can get down, I've improved on a root filling and things have generally gone well, I'll get something on straight away. I can't see a reason for deferring. And I don't think, I mean, retreatment success is about 10% less, but done well should still be successful. Only caveat, if something doesn't go well, if I can't get a fracture instrument out or something else, I might defer it then. A lot of retreatment cases may already have crowns on, so you don't tend to need to put a new one on. And again, if a tooth's been root treated and the crown is well fitting and looks to be in a good position, I'd leave it there. I don't necessarily commit them to a new crown if the marginal fit is good.
Okay. Thank you very much. I'm sure Nick and both Ian will take questions during the lunch hour if you have any more questions. I have a few announcements to make, but just before that, if we could thank Nick again for an excellent presentation. Thank you.